All right, everyone. We're going to go ahead and get started we have about 60 minutes, so I don't want to waste any time. LaShonda, are you on the line?
I am on the line.
All right, if you'd like to go ahead and start us off with the introduction, and we'll get the ball rolling.
Okay, well, my name is LaShonda Petaway Brown, and I am a quality improvement consultant here at the Office of Rural Health. And I just want to thank you all for participating on the South Carolina Office of Rural Health Practice Support Toolbox webinar. This is our second quarterly webinar, and the purpose of this webinar is just to provide opportunities to other practices that um, and learn more about other organizations, tools, and resources that are available to support them with practice management, clinical management, and overall practice transformation. Today I'm going to introduce three organizations that will be presenting and providing you some information about their organization and different projects that they're working on. The first organization I would like to introduce is South Carolina DHEC, and that is Kay Louder. The second organization I would like to introduce is SCIEX, and we have Liz Hanson. The third and final organization that we'll be presenting today is the Carolina Center for Medical Excellence. We have Angela McCrae, Jennifer Boyd, and Melinda Postal. If time permits, we will have some additional questions at the end of the webinar. Contact information for each organization will also be provided. So with that being said, we'll go ahead and kick off the webinar with Kay Louder from South Carolina DHEC.
Hi, I'm Kay Louder, the Community Clinical Linkages Coordinator for DHEC's Division of Diabetes, Heart Disease, Obesity, and School Health. I'm going to give you an overview of our two CDC-funded grants that support our hypertension management program, diabetes self-management program, and activities in South Carolina phase. Next slide, please. I'd like to start with providing you some data about the burden of heart disease and diabetes in South Carolina. Heart disease is the leading cause of death in South Carolina, and 2 out of every 5 adults in South Carolina have hypertension, which is a major risk factor for heart disease. Diabetes is the 7th leading cause of death in South Carolina, and 1 in 8 adults in South Carolina has diabetes. 2 out of 5 people with diabetes in South Carolina have not taken a diabetes self-management education class. Next slide, please. The 1305 grant is one of 2 CDC-funded grants supporting our efforts in reducing the impact of heart disease and diabetes in our state. The DHEC 1305 grant, which by the way is named by the number assigned to it by the CDC, otherwise it has much too long a name, the purpose is to support statewide implementation of cross-cutting approaches to promote health and prevent chronic disease and related risk factors. It's housed in the Diabetes, Heart Disease, Obesity, Prevention, and School Health Division. And the 4 items I list here are the areas of focus for the grant. I'm going to speak to number 3, health systems integration, and number 4, community clinical linkages today. Next slide. Under the 1305 grant, we offer 2 programs to medical practices, the Hypertension Management Program and the Diabetes Self-Management Education Training Program. The Hypertension Management Program focuses on improving patient health outcomes through using evidence-based guidelines to manage hypertension. The program is implemented across the state with the exception of the following counties that are listed here. And by the way, you'll find that these are 1422 counties or South Carolina phase counties when I get further into my presentation. Why participate in the program? Participation will help your practice meet pay performance and quality improvement goals and better help you manage your patient's blood pressure. Next slide, please. In order for a practice to participate, they need to provide the following information. And by the way, it's through contractual agreement with the practices that these programs take place. We offer funding, and currently through level funding for the coming year, which begins June 30th, we offer up to $5,000 to support implementation of the program. And we offer technical assistance for identifying evidence-based guidelines for hypertension management, promoting a team-based care approach in management of hypertension, providing educational tools for proper self-management of blood pressure, funding and technical assistance to support EHR modifications, online community resource directory with bidirectional capabilities, and assistance in identifying and applying for additional financial support to purchase automated self-monitoring blood pressure devices. And we do have a resource right now with our Wise Women program for some of those. It's a limited number, but we do have that available to us for the coming year. The EHR, practices also will have a responsibility of EHR modifications that include collecting data on blood pressure at each visit, incorporating evidence-based hypertension management guidelines into the EHR algorithm for treatment of hypertension, documenting the education provided at each visit specific to need, demonstrating and documenting the understanding of patient education received, and identifying patients with undiagnosed hypertension. And those can be patients who have not been seen by a provider in the past 6 months, or those who have had documented high blood pressure in the last 2 appointments but have not received a diagnosis of hypertension. We also support EHR modification to develop patient recall systems for patients with undiagnosed hypertension. And practice responsibilities also include, I think that's the next slide, next slide. I'll keep going. Practice responsibilities include adopting a protocol for team-based care that supports self-management of blood pressure tied to clinical support, including the ability to relay communications between the patient and the provider. And utilizing an educational tool for proper self-monitoring of blood pressure for use by non-physician team members. And we require semi-annual and annual progress reports that include aggregate data such as the number of patients with hypertension. Okay, next slide, and I think I got ahead. There you go. The Diabetes Self-Management Education Program is the second program offered through the 1305 grant. Diabetes is an interactive, ongoing process involving the person with diabetes or a caregiver and a diabetes educator. Through this collaborative process, people with or at risk for diabetes can gain the knowledge and skills needed to modify their behavior and successfully self-manage the disease and its related condition. The program focuses on the American Association of Diabetes Educators, that's AADE, 7 self-behaviors that are essential for improved health status and quality of life. The 7 self-care behaviors are healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risks. Our free DSMET curriculum has been developed using these 7 self-behaviors. The DSME program is reimbursable by South Carolina Medicare Part B, Medicaid, and many private insurers. To be reimbursable, the DSME program must be recognized by the American Diabetes Association or accredited by the American Association of Diabetes Educators. To become an accredited DSME program, classes must be taught by licensed healthcare professionals such as registered nurses, registered dietitians, and pharmacists who specialize in helping people with diabetes understand how to best manage their disease. And why would you refer your patients to a DSME program? To increase the practice's efficiency by assuming time-consuming patient training, counseling, and follow-up duties, to help meet your pay performance and quality improvement goals, and to help you manage your patient's metabolic control, lipid levels, and blood pressure. Next slide. The DSME program is implemented statewide. There are no limitations in counties. And it provides funding and technical assistance to support the development of American Association of Diabetes Educators accredited DSME programs. Based on current funding levels, the DSME program provides up to $15,000 to support the development of AAD accredited programs. The funding supports funding support is available for supplies such as laptops, projectors, and food models used to teach DSME classes. Technical assistance includes our free DHEC developed curriculum following the AADE guidelines, free class handouts, and DHEC developed accreditation application templates, and we have a 100% success rate for those who do use our template. Next slide. DSME program practice responsibilities include identifying staff or a certified diabetes educator for your DSME trainer team. As I said before, the DSME team must be licensed medical professionals from different disciplines, such as medical doctor, registered nurse, registered dietitian, or pharmacist. The practice must document diabetes-related CEUs for their DSME trainer team. They must use our DHEC curriculum. They must develop their DSME classes based on the curriculum, apply for DSME AADE accreditation, identify and refer patients with prediabetes to a national diabetes prevention program. And we provide a resource directory with bidirectional capability to practices to support the referrals to the national diabetes prevention programs and other community resources. We also require that you submit semi-annual and annual progress reports, and the progress reports include aggregated data such as the number of patients with diabetes in the practice. Practices are contracted with DHEC for up to 1 year to develop their program and attain AADE accreditation. Next slide, please. Our second CDC funding grant is the 1422 or South Carolina phase, and that stands for South Carolina Prevention and Health Across Systems and Environments. Its purpose is to support implementation priority population approaches to prevent obesity, diabetes, heart disease, and reduce health disparities among adults. It's housed in the same division, diabetes, heart disease, obesity prevention, and school health. And these 16 targeted counties are those that are only available for 1422, that is not statewide. SE phase is structured under 2 CDC required components. I think that's the next slide. There you go. The first component, component 1, includes specific strategies on worksite wellness, healthy food access, open community use, pedestrian planning, and implementing evidence-based engagement strategies to build support for lifestyle change, such as the National Diabetes Prevention Program I've mentioned. Component 2, the one we'll be discussing today, includes specific strategies that focus on utilization of electronic health records, modification of those records, quality improvement, monitoring, team-based care practices, chronic disease self-management, community health worker engagement, engagement of community practices, and implementation of bidirectional referral systems. The next slide, please. Funding is based on level funding from this year for contracted practices to receive up to $14,000 to meet contractual deliverables. This amount may change based on changes in the grant budget for next year, and the grant year for the South Carolina phase begins September 30th of each year. DHEC will provide technical assistance to modify electronic health records to collect data on various blood pressure and A1C measures. We provide technical assistance also to integrate evidence-based hypertension and prediabetes algorithms into the EHR that promote medication adherence, develop and adopt a policy that supports team-based care for hypertension, diabetes, prediabetes, to include the use of non-physician team members, technical assistance to identify and share policies, protocols supporting self-monitoring of high blood pressure linked to self-management plan, and provide technical assistance to develop and adopt such protocols. And to become a CDC National Diabetes Prevention location or actively refer to patients to a recognized National Diabetes Prevention Program. Also provide technical assistance to support community health workers in linking patients to community resources available in a data management system. Assisting with training of CHWs for the management of uncontrolled diabetes, prediabetes, undiagnosed hypertension and/or uncontrolled hypertension, and to assist in identifying funding opportunities to support the purchase of self-monitoring blood pressure devices. Next slide. Practice responsibilities include EHR modifications that can include collecting data on blood pressure at each visit, incorporating evidence-based hypertension management guidelines into EHR algorithms for the treatment of hypertension, documenting education provided at visits specific to need, demonstrating and documenting understanding of education received, and identifying those patients who are with undiagnosed hypertension, who have not been seen by a provider in the past 6 months, or who have high blood pressure have had high blood pressure documented in the last 2 visits but have not received a diagnosis of hypertension, and developing a recall system for patients with undiagnosed hypertension. Next. Also, excuse me, one slide back. I got ahead of myself. If you could go one slide back, the responsibilities of the practices also includes adopting a protocol for team-based care that supports self-management of blood pressure to tied to clinical support, including the ability to relay communication between the patient and provider, utilizing an educational tool for proper self-monitoring of blood pressure for use by non-physician team members, utilizing a DHEC-provided data management system with bidirectional communication for community resource referral and follow-up. You also provide, the practices also must participate in semi-annual and annual progress reports, again, that include aggregated data. Next slide. Another program offered by our division under both grants is what program I mentioned before, the National Diabetes Prevention Program. The National DPP is a CDC evidence-based year-long lifestyle change program that has been developed to prevent or delay type 2 diabetes and reduce CVD risk factors and events. It offers trained lifestyle coaches, CDC-approved curriculum, group support, 16 weekly meetings, and 6 monthly follow-up meetings to maintain healthy lifestyle changes. To be eligible, patients must be at least 18 years old and be overweight with a BMI greater or equal to 24. They must be they can be self-reported based on a risk assessment or have a diagnosis of prediabetes or gestational diabetes based on fasting blood glucose, 2-hour glucose, or HbA1c. And why refer patients to this program? This is an evidence-based program that reduces patient risk of developing type 2 diabetes by 58%. It reduces CVD risk and provides a resource for patients wanting to make a lifestyle change. And before ending my presentation, I'd like to mention some of the partners that have assisted in all strategies and components of these grants. They include the South Carolina Office of Rural Health, Blue Cross Blue Shield of South Carolina, Care Coordination Institute, Department of Health and Environmental Controls, DHEC Public Health Regions, Office of Minority Health, Cancer Prevention and Control, Office of Public Health Nutrition, the Department of Health and Human Services, Eat Smart Move More of South Carolina, the South Carolina Department of Agriculture, the South Carolina Hospital Association's Working Well Program, South Carolina Food Access Task Force, the South Carolina Pharmacy Association, the Carolina Center for Medical Excellence, and the Carolinas, Georgia, and Florida chapter of the American Society of Hypertension, better known as ASH. And the next slide, there you go, this slide. You can contact me, Kay Louder, if you need more, you'd like more information about the hypertension management and DSME programs. Tina Marie Devlin regarding the South Carolina phase, and Michelle Moody for the National Diabetes Prevention Program. Thanks for your time, and I'll be glad to answer questions at the end of the program.
Thanks so much, Kay. Up next is Liz Hanson with South Carolina Information Exchange.
Thank you. Next slide, please. So briefly, what I'm going to cover today is what an HIE is, which is what South Carolina Health Information Exchange is. I'm going to talk a little bit about what SCIEX is, how it can help you in facilitating meaningful use and future requirements of meaningful use, and then lastly, how to participate. And I do notice that the bottom of the slides are cut off, Andrew, so I don't know if that's if everyone's missing the bottom of the slides or if it's just me. So I'll try to make sure I cover everything on the slides. Next slide, please. So first, I just want to share with you what an HIE is and to let you know that the grant that supports our efforts for this year and next is an interoperability grant. And an HIE is a health information exchange, and it is a method of transmitting healthcare data between facilities, health information organizations, and government agencies. And this has to be done per national standards and security and privacy requirements. Next slide, please. So the purpose of an HIE is to electronically move clinical information between healthcare providers and health information systems. The purpose is to facilitate access and retrieval of clinical data from all types of providers, to provide a safer, more timely, efficient, effective method for moving patient data, and I'll talk a little bit more about that, and to provide useful public health authorities with data. And many of you that are participating with Meaningful Use have faced the issue of registries, and one of the purposes of an HIE is to support the use of registries and the transmission of data to registries. Next slide, please. So the goal of an HIE, and is certainly the goal of your state HIE, is to have all caregivers achieve interoperability or the exchange and consumption of patient data regardless of their system throughout the country, anytime, any place, anywhere. Next slide, please. So that brings us to SCORH. And again, it's a little bit of an issue because I can't see all of the slide. I don't know quite why it's not all showing. But SCORH is your state health information exchange. It is funded by participation. It is a nonprofit organization. And SCORH has recently received a federal grant, a 2-year grant, to provide greater support to providers within the state to exchange information. So SCORH specifically is a set of policies, technology services, and interoperability standards that enable trusted electronic exchange of clinical information. And interoperability means that you can exchange the information and utilize that information within your EHR. And an example of that would be that you could receive a document from another provider and you could incorporate their medications within your system without rekeying those medications. And we call that the consumption of exchange data, and I'll talk a little bit more about that. The goal of SCORH is to provide a patient's information to any provider that needs it, when and where it's needed for the best possible care throughout the state. Next slide, please. So specifically, SCORH provides a framework for this information exchange to be completed securely and efficiently. So we'd like to use the analogy that utilizing SCORH is like getting on a superhighway for information exchange. So if you're faxing over documents, then we might consider that using a county road. And if you're exchanging paper documents, then we would consider that utilizing a dirt road. And Andrew, I know you're trying, but I still can't see quite all of it. So SCORH provides the interstate or the superhighway, the fastest, and in theory, more so than a highway would be, the safest method for exchanging information. We provide a participation agreement that provides access to the highway that all members must sign. We have a policy manual, which is the rules of the road that everyone has to participate in. And then we provide the tools and technology to facilitate you moving. So we give you the rules, we give you access, and then we give you the vehicle or the car to get on the highway and move your information. The carport or the garage is going to be your EHR. Next slide, please. So SCORH actually provides 3 different types of services. I'm not going to read out each of these little tiny cells for you to look at, but hopefully you can have access to the presentation and might look at these, or you might go on our website to get more information or give me a call. But we have 3 different services. The most robust service, or the one where we want everyone to be, and the government would like for everyone to be by 2017, is the query-based exchange, and this is where you push information from your office or your health clinic out to SCORH for anyone to access, and it gives you the ability to access documents that are made available by other entities. So again, that's the robust exchange, where you can exchange documents bidirectionally with other providers in a pooled environment, if you will, where everyone could access that same information. For example, if a hospital released a patient and you needed access on it, but perhaps the rehab folks would actually also need access, or maybe long-term care would also need access, then you would all simultaneously be able to access this information. I'll talk a little bit more about what that information that's made available is. The next service provided by SCORH is your clinical viewer, and this is where you can view information provided by other entities, but you may not be providing information from your entity. This is specifically important for areas or providers who might not have an EHR or might not have a certified EHR. And this is true with many of our behavioral health organizations, our mental health facilities, long-term care, home health facilities. A great many of them in the state do not have a certified EHR, so they can't provide this, they can't push out documents to SCORH that's in a standard format for you to utilize, but they can access the information that you would provide. So a clinical viewer is available to everyone that's on the system, but if you had the query-based exchange, you wouldn't choose it. Typically, we have the mental health, the skilled nursing homes, those types of folks are currently the ones that are getting the most use out of the clinical viewer. But it does allow them to see the information that's provided by clinics and practices and hospitals that do have EHRs. The third service provided by SCORH is perhaps the most popular, and that's the direct secure messaging. Now, this may resonate with many of you who are participating in meaningful use, and it does reflect a little bit back to, all of this reflects a little bit back to what Kay was discussing, but direct secure messaging is the most popular method for exchanging documentation to meet that dreaded summary of care requirement for referrals for meaningful use. The trick for direct secure messaging is you have to send it to someone who also has a direct secure message system. So one of the benefits of the grant that we've recently received is to allow our field team to go out and work with practices and other entities not considered eligible professionals for meaningful use to help everyone utilize specifically direct secure messaging and eventually clinical viewer and the robust exchange to meet meaningful use requirements and other requirements that will be connected with your upcoming macro payment systems. Next slide, please. So this is just a nice graphic with SCORH in the middle to show that we want to tie together all of these entities to give you the information to securely exchange information and to receive information that's provided regardless of who the entity is or what the healthcare provider is providing for. And this would include not just hospitals, not just clinical practices and medical practices, but also long-term care facilities, rehabilitation facilities, mental and behavioral health facilities, and the like. It would also include Department of Social Services. Some folks need access to the court system. So our goal is to connect everyone that has information and needs to exchange it about a patient and their health. Next slide, please. So, with that said, we'd like to talk a little bit about how SCORH can facilitate meeting meaningful use requirements. And I'm not going to get into meaningful use too deeply or defend why you have to do it. Other than that, you want to get those reimbursements if you're participating with Medicare, and you want to get the incentive payment if you're participating with Medicaid. So we just want to go through how we can help you do that. Next slide, please. So when we look at how SCORH can help you meet meaningful use, then we have a few goals in mind. We want to help you share the electronic patient record. We want to help you meet the modified stage 2 meaningful use requirements. We want to help you meet the new MACRA meaningful use requirements. And we definitely want to support the exchange of health documentation and the continuity of care sequence between all providers. And I actually think there might be something at the bottom of that slide that I can't see, but hopefully I'm not missing anything. Oh, all of these purposes can be impacted by an HIE and specifically by SCORH. Next slide, please. So just real quickly, just wanted to highlight, some of you know this much better than you would like to know this, and these are what the goals or what the definition is around meaningful use, so that we can relate this to what an HIE or what SCORH can do to help you meet it. So meaningful use is defined as the use of a certified electronic health record to improve quality, safety, efficiency, and reduce health disparities, which is important in a state like ours. It is to help engage patients and family, and yes, that relates to the dreaded patient portal, and hopefully many of you are having success with that, but a lot of you are not. The purpose of meaningful use is to improve care coordination and population and public health. Care coordination is certainly reflected in meaningful use through the summary of care, exchange for referrals, and transfer of information. Your population and public health information is part of your registry requirements. And also meaningful use supports maintaining privacy and security of patient health information, and all of these can be impacted by an HIE. Specifically, the privacy and security is protected by the requirements and the national requirements that SCORH had to meet to become a state health information exchange. Next slide, please. So this particular slide actually goes over the requirements in the modified stage 2 meaningful use measures. On my screen, number 10 is cut off. I hope you can see it. If not, I will still cover it. What I've done is highlighted the ones or bolded the ones that SCORH can assist you with. Number 1 is to protect the patient health information. This specifically for meaningful use is completing your risk assessment. And of course, if you've been audited, you know that if you don't have your risk assessment and your mitigation plan dated, you will not pass this part of your audit. And the way that SCORH can support this requirement is by providing you a safe method for information exchange in a secure environment, which is part of your risk assessment questions. Number 5, health information exchange is actually right now defined as your e-summary of care or the exchange of your continuity of care document. I'll talk a little bit more about that in a second. Medication reconciliation can also be assisted with your health information exchange. And then at the bottom, number 10, your public health and clinical data registry reporting, which you may not be able to see, which is certainly part of meaningful use and certainly given us some struggles most recently. So those are the areas that specifically can be impacted. Some states did receive a grant to assist with a consumer or patient engagement tool. We did not receive that grant, but we continue to ask the feds, I should not have said that, continue to ask the federal government to provide us with money to help you with your patient portal requirements, but not now. And of course, secure messaging, as it stands now, is a requirement where you transmit to your patient, and you would do that through the portal, not through your health information exchange. Next slide, please. So I've already talked a little bit about your direct secure messaging, which is the most used service from SCORH. So direct secure messaging allows you to send electronic summary of cares, which are also called the ESOCs. Typically, you would send a CCD, which is a continuity of care document, which is that document that is generated out of your EHR when you push the right buttons to create a summary of care document. Please understand this is not the clinical summary. This is not the document that you gave to patients as a walkout document. This is a document that can be used between providers or caregivers. Direct Trust is a service that we offer that allows you to connect to SCORH Direct Secure Messaging through a certified EHR if they already have a direct messaging system set up. Some of you may have gotten your direct secure messaging through your EHR and found that you couldn't exchange with other EHRs. Having a direct trust system set up, and that's a technical term that is used for this service, then that would allow you to exchange. For instance, if you had an Allscripts or any clinical and wanted to exchange with each other, you would want a direct trust environment in order to do that. And SCORH can provide, will be able to provide that for you within the next month or so. We do want to note that to you that if you receive a summary of care electronically, you always want to review this before you upload it or attach it to your patient system. Eventually, many of you will learn how to consume this document or upload this document so that it not only is an attachment to the patient record, but it populates the patient record. Clinical Viewer allows you to query, view, and download information or upload, whichever you prefer to use, and is not usable in an environment where there is no EHR. And of course, it allows you to send, receive, and integrate, which is the term I keep using consume for. In other words, you can take information and put it into your system, not just as an attached document. Next slide, please. And this is just a picture of what direct secure messaging looks like. You sign into a portal just the way you would sign into your email box, and you access your direct secure messages just like you would access an email. The difference is this is a national standard for secure information exchange, and is the best way to exchange patient information if you're not using a query base or exchanging it totally through the health information exchange. This is also good for just sending general messages or communications through to other providers, which you would not do in a clinical viewer environment. So if you just wanted, let's say you wanted to know, get an alert from a hospital that one of your patients was being discharged, they may push out that discharge summary, or they may send you a direct secure message telling you that your patient has been discharged. And we call these alerts. And this is a very popular application and very convenient for practices in that continuity of care environment. So there are multiple ways to use direct secure messaging to communicate with other providers, to exchange clinical data securely. And the good thing about this is we have many practices that are concerned about not knowing when to go check their portal. This is one of the things that our field staff can help you change the workflow on so that you know when to check it, how to check it, and you can actually get email alerts saying you have a direct secure message in your regular email. So it is a lovely tool, very easy to use, and if any of you would like to take a closer look at it, it's very easy for us to do demonstrations and show you what this particular tool looks like. Next slide, please. And this is a sample of a continuity of care document, or what we call a CCD, and it is pretty standardized. It is intended to be standard between and among all EHR systems. This is one of the documents that all your EHR systems must generate to get certification. And as you can see on the left, you have a table of contents. You would simply click on the area that you want to review, and it would bring up that particular area. So if you wanted medications, you could click on medications. And if you were using the clinical viewer, you could actually upload those medications into your EHR without rekeying them, which is a really nice ability. We're sorry to say that many folks are not able to use that through their EHRs yet, but if you are, then we have a team that would love to come help show you that, and that the grant that we have provides for us to give you those field services. So that is your continuity of care document. One of the things we have found is although this gives us more standardized information than we've ever exchanged in the history of medicine, we still have folks that would like more information. So I guess that's the irony of all of it. We can see in the future that this will be expanded, but in the short term, you could always use direct secure messaging to send any other non-standardized information. Next slide, please. I did just speak for a moment about how direct secure messaging can support your patient health information protection or answers to your risk analysis, which is a meaningful use requirement. I've mentioned several times that you can use it for medication reconciliation. This is wonderful because it doesn't make you completely dependent on the patient bringing in their bag of medication for you to sort through to see what they're actually using. The more providers that are on the system and providing medication lists through their CCD, the better. Eventually, you wouldn't have to use that access at all. And I think you skipped to the next slide without me saying to. Could you back up, please? Okay, thank you very much. So medication reconciliation will be at a point where it will be able to be consumed within your system. And so we're very excited about that. But we do know that many practices are already achieving certainly some economies and certainly some benefits by not having to be totally dependent on the patient for what medications they're taking, but be able to see what other providers have prescribed rather than being dependent on the patient. And of course, if you don't have to rekey the data, then it is reducing errors. Now I'm ready for that next slide. So this next slide talks about public registries. This has given a great many of us problems in meeting meaningful use, but your state information exchange, your SCIEX, does provide a bidirectional reporting system for your immunization registry, and that is available today. When it is available to all caregivers, right now syndromic surveillance is only available for hospitals and urgent care centers, but when it becomes available for everyone, then you will be able to utilize SCIEX for reporting syndromic surveillance to meet meaningful use. And we are also working with the cancer registry to facilitate utilizing that registry. We do foresee facilitating the use of more registries in the future. I know many of you are working towards your specialty registries, and those are not available through SCIEX at the moment, but that is something that we do foresee could happen in the future, but not this year. Next slide, please. So this is just a brief glance. We had a lot of rumors about, meaningful use is going to go away and we're not going to have to do this anymore, and of course, we found that that wasn't true. So we just wanted to let you see a quote from the CMS Acting Administrator, and actually this is a quote from the Office of the National Coordinator as well, that they are very serious about interoperability and will continue to increase the requirements for health information exchange. And so we want to get you using the system as quickly as possible so that you don't wait until you're bombarded with requirements until it's part of your entire reimbursement system, which is going to come along with MACRA and the requirements associated with the MACRA payment system. Next slide, please. This is a look at the next phase of meaningful use. Some of you may have already looked over the new MACRA requirements and know that this will account for 25% of your scorecard for the MACRA reimbursement system. Included in these requirements is a coordination of care requirement a health information exchange requirement, interoperability, and registries. All of these are areas that are provided for today through SCIEX and will continue to be provided for when those new requirements become active in 2017 and more formal in 2018. So we just want to let you know that we are aware of these requirements and can already facilitate all of these at this point in time. The great news is right now we've got a grant that will help us help you do that. Next slide, please. This is just a few points about how the robust exchange that I talked to earlier in the presentation, where you push information out into the network and you can receive it as well, a bidirectional push and pull of clinical information, is really reflected in the requirements for interoperability and will be required in the next phase of your meaningful use measures. So we just want to give you a little bit of background on that. Next slide, please. And this is just another graphic. We don't have time to go over it. It looks similar to the other one, but the point is, any place, anytime, any provider needs patient information. Next slide, please. And I should say that the health information exchange is only as usable and only has the most value when everyone is participating. So it's very important that you begin to look into participating in the health information exchange before it becomes a total requirement. I know you may have heard that the state of North Carolina has mandated that all hospitals participate in their health information exchange fully by 2017, and that hasn't happened in South Carolina yet, but the federal government has committed to making this a requirement. So we just want it to happen for you before it becomes a full requirement. So how can you connect? You can connect your SCIEX staff. You can also connect with your folks from the Office of Rural Health or from CCME. Both of those participants on the presentation today do work very closely and help facilitate the use of SCIEX. So we encourage you to contact them as well if you would like. When you contact us, then we would need your EHR contact information so we can communicate and connect most effectively with them. You would obtain training in how to do a query. You would obtain training in how to use direct secure messaging. And we would also ask that you give us a referral list of the other practices, hospital systems, long-term care systems, what other caregivers you need to communicate with. We'd like a list of them so we can go help them as well. And then, of course, the big thing is you need to use it. And that's one of the reasons we really want to take advantage of this grant over the next year and a half so we can help teach you how to use it. Next slide, please. What will our team do if we come into your practice? The first thing we'll do is we will do a workflow needs analysis. We'll look at how you're exchanging right now in a practice environment or rural health center environment. We'll look at how you are exchanging your continuity of care documents or your summary of care documents to meet meaningful use. And we'll talk to you about how you might need to change that workflow a little to make it work consistently within your practice to meet meaningful use. And then we'll tie in SCIEX to show you how to do that last step of sending it. So we'll do the needs analysis. We'll help you with the workflow redesign and guidance. We will contact other providers in your community of care to help get them connected. We will work with your vendors. We'll provide training and we'll provide follow-up, because we found that even if we get you trained, we might walk out the door and you might forget how to do it, or you just might not do it. And sometimes we need to to come back and help a little bit more. We will also assist you with tracking. Some of your systems will not track for meaningful use information that is exchanged through direct secure messaging outside of your EHR, and we can support you on the tracking of that information. And we can provide a directory of what other providers in your community of care are on the system currently. Next slide, please. So who participates in SCORH currently? We have over 60 organizations that currently participate. 17 of these are hospital systems and all the providers and facilities associated with them. We have hundreds of providers within all of these systems. We have connected with mental health, behavioral health, and part of our grant is also to work with long-term care, which is your skilled nursing homes, hospice, and your home health care. And so we do have grant funding to provide them access at no charge. To date, we have had over 1 million distinct patients registered with SCORH, and we've actually had over 5 million documents registered with SCORH. So there is a lot of information already out there, and it grows exponentially every day. Next slide, please.
And Liz, if you don't mind, would you go ahead and start wrapping up, please?
I will. So in closing, and so you can go ahead and go on to the end, there is a participation fee, and you can stop there. There is a participation fee that is typically $230 per year per provider. There are different fee schedules for hospital systems or rural health systems and the providers that participate with them. And there's also a different fee schedule for some organizations like CCME. There is some contact information, and I think at the beginning and at the end, will you go one more slide, please? Andrew, I think I have one more slide, and there is, at the bottom of the slide that I can't see, hopefully you can, is my contact information. So we do welcome your participation, we welcome your questions, and are glad to give you demonstrations. Thank you.
Liz, thank you so much for that information. Next, we have CCME, the Carolina Center for Medical Excellence. We have Angela McCrae, Jennifer Boyd, and Melinda Posel.
All right. Thank you, LaShonda. My name is Angela McCrae, and I'm a quality specialist for the Carolina Center for Medical Excellence. The Carolina Center for Medical Excellence is part of AQIN, a Quality Innovative Network. We serve as the QIN/QIO for the state of South Carolina, and we're also known as AQIN South Carolina. The CCME mission, we help people by improving the quality of health care. Next slide. So as a QA specialist at CCME, areas that I work on includes the Cardiac Learning and Action Network. The goal of this work is to support the Millions Hearts campaign to reduce heart disease by 1 million by 2017. Ways that we support this campaign includes monthly webinars that provide education and tools on cardiac prevention. We partner with different organizations to help promote cardiac prevention, such as the DHEC program that Kay spoke about earlier. Currently, we are partnering with the Johns Hopkins and the American Medical Association to bring a blood pressure quality improvement program to the state of South Carolina. Some highlights of this program include peer-to-peer learning, evidence-based tools and resources. It aligns with the Millions Hearts campaign. It offers CMEs. It's designed for the busy practice, and it's to no cost. Also, it's an 8-month-long program that meets once a month. The monthly webinars are recorded, so if you missed a webinar, you can listen at your own convenience, and you will get a certificate on completion of the program. If there's something you're interested in, please feel free to send me an email. And just as an FYI, participations in our land, participants are free to participate as little or as much as you choose. Next slide. Other areas that I work in are the quality reporting through value-based payment. This includes PQRS, the value-based modifier, the quality resource use report, and if you're not familiar with that report, it's basically a report card from CMS as to how you're performing under the value-based modifier program. And then beginning in 2017, we'll be working with MIF, the Merit-Based Incentive Payment System. Next slide. So we provide technical assistance in all of these areas through one-on-one coaching calls. We do site visits as requested, and educational webinars. We promote and assist in sharing best practices. We provide access to resources and tools. We provide a monthly Partners in Practice newsletter that will help you keep up to date on these quality initiatives. And then finally, we partner and collaborate with stakeholders with the same goals and similar initiatives. If you need assistance in any of these areas, please feel free to contact me. And even if you don't need any assistance in these areas, by working with us, we can keep you up to date on changes to these initiatives, be it our newsletter and our monthly webinars. Also, as a reminder, as the QIO for the state of South Carolina, all of our services are provided at no cost to you. Now we're going to hear from Jennifer Boyd. Jennifer is going to speak on our diabetes program and our Meaningful Use program. Thank you.
Thank you, Angie. I appreciate that introduction. Next slide, please. Okay, so something I want to cover real quick, and I know we have a timeliness issue here. So just to cover real quick, the goal of our diabetes work, and Kate spoke a little bit earlier about their diabetic work and kind of similar to what she is doing through her work efforts. We're really looking at, everyone with diabetes counts. We want to focus on improving their health care and looking specifically at those measures listed, the hemoglobin A1C, the lipids, the blood pressure, and the weight control. We also want to look at the diabetes self-management and the tools that it can provide our beneficiaries, and we want to help them to improve their diabetes and to reduce any disparities. Under our work with CMS, our goal is to educate 2174 beneficiaries and have all of them graduate from the DSME program by July 31st, 2019. During the DSME workshop, we have two different options where we have the Living Health with Diabetes, Don't Forget, Get Answers. That workshop consists of 2-hour sessions for a 5-week period of time for our beneficiaries. The next session, a workshop that we offer, is a 6-week workshop, which is using the Stanford Diabetes Self-Management Program. We offer all of these DSME workshops for free and certainly would like to work with any of your patients. So if you want CCME to work with your practices and or your patients, we would ask that you reach out to our lead on the diabetes work, which is Sharon Eubanks. It is on the slide. I don't know that everybody can see that. But if Andrew is going to share that, you certainly feel free to reach out to Sharon Eubanks. And we'll move forward to the Meaningful Use. If you can, next slide, please. And for our Meaningful Use work, and Liz covered in wonderful detail all of the Meaningful Use requirements that we have over the next several years. But our goal under our program is to assist providers and hospitals in their quality improvement efforts in the HFT advancement, is utilizing the EHR to meet the Meaningful Use Quality Initiative program, and also look at the patient engagement effort. We deliver our services through these technical assistance efforts where we will work with our practices on their data, making sure that they're trending and tracking for meeting the measures, if not some workflow suggestions, or even hopping on the telephone with their vendor to kind of get some workflow direction directly from the vendor. We can do that work via on-site phone calls and email communications. We also, as Angie mentioned earlier, we do have a way of sharing our information and resources, any pertinent information that may come in via our email blast that we send out, monthly webinars, and also monthly newsletters. We also work with multiple stakeholders in the state of South Carolina. As Liz mentioned, we do have South Carolina Health Information Exchange that we're working with to promote an increased interoperability piece. Hopefully our practices will on board more with SCIEX. As you could see from Liz's presentation, they have many great things to offer. We also have, obviously, the South Carolina Office of Rural Health that we partner with, and the Primary Healthcare Association. We're also working with DHEC on their efforts, and so we're very lucky to have these wonderful partners and stakeholders in the state of South Carolina that we can assist them in their efforts, and they can assist us in our efforts. If you need any information related to the Meaningful Use piece in general, again, you contact me, Jennifer Boyd. My information is listed at the bottom of the screen. And as Angie mentioned, this is a no cost to our practices and our hospitals, as this is covered under our grant with CMS. So I know that was very quick, but again, in the interest of time, Just wanted to kind of give you a brief overview of what we do under this section of our work, and I'm going to transition it now over to Melinda Postal to give a brief overview of additional work that we do.
Thank you, Jennifer. Thank you for changing the slide. My name is Melinda Postal. I want to talk to you today about two initiatives underway at CCME. Relatively new to CCME's task work is an initiative to increase immunizations for flu, pneumonia, and herpes zoster. Our goals align with the immunization goals for Healthy People 2020 to increase immunization rates and reduce preventable infectious diseases. So we will do this by working to improve assessment and documentation of immunizations, target minority and underserved populations, and aim to increase provider reporting of immunizations to the state immunization registry. Part of this initiative is state-based immunization coalition, which was established this past year and brings together multifaceted experiences and perspectives from providers, stakeholders, and Medicare beneficiaries. We meet quarterly, all working together for broad message spread to ensure that people receive the right immunizations, but also that we make sure that these efforts are sustained beyond the life of this federal contract. Several activities are already underway with this group of more than 90 participants who meet quarterly, both in person and through webinars, including the development of a website where we share information, including meeting materials, presentations, an electronic newsletter that can be shared with facilities and communities, and this newsletter is co-authored by DHEC. So we also engage our coalition members to participate in it as well. So we are working on identifying strategies using immunization data specifically to target low-rate areas and focusing on engaging with providers and community members. And I encourage you, if you'd like to participate in this immunization coalition, to please contact me. And my information is on the next slide, which we can go ahead to. So Transforming Clinical Practice Initiative, this CCME received a contract with CMS to service the TCPI work in South Carolina, and TCPI assists clinicians in improving the way they deliver care by providing technical assistance support, integrating quality and process improvement, and by applying and sharing practice transformation tools and educational materials. There are 4 practice transformation networks in South Carolina who help clinicians throughout the transformation process and who conduct assessments to see what stage of transformation they are in. CCME's role is to validate the scoring of the assessments, and we work collaboratively with the PTNs in the state during the assessment process to address questions and provide any guidance as needed. The 4 PTNs are noted on the slide: Community Care of North Carolina, COSEC, the National Rural, and Vizient. And I've listed the contacts there if anyone is interested in contacting them to enroll in TCPI. And thank you, and I'll turn it over to you, LaShonda.
All right, well, my name is Andrew Chandler, and I'll actually be closing this out for the webinar this afternoon. And first of all, I'd like to thank all of our presenters, DHEC, SCIEX, and the CCME staff for presenting. There's some really great things going on in the state of South Carolina, and we found that each of these opportunities and tools will be very beneficial to advance practices and to take care of the patients with more ease. And so I will be sending out a copy of the slides. I do apologize for the technical difficulty. I did not want to interrupt the webinar. But I will save these slides as a PDF, and I will make sure they get to all the presenters and participants. I do have a list of that, and I will share that. Also, as far as the recording, I will have a recording of this if anybody would like to receive a copy. We will also put it onto our YouTube page, and we can have people have access to that for those who may not be able to attend today, or if you all would like to rewatch to find out some more information. I do have our contact information on here for the South Carolina Office of Rural Health. Please don't hesitate to reach out to us for anything we can be of assistance with. I do have everybody, all the presenters, contact information. We're happy to share that. Please take advantage of these resources. They are out there. Some of them are free to you, but many of them will help the care, advance the care. So With that, we will close out the webinar. I will stay on the line if anybody has any questions that, or feel free to put them into the chat box. So once again, thank you so much, and take care.
Thank you.
Thank you, Andrew.